On intriguing questions after a perfect cataract surgery. I would like to request my co-instructors and the speakers to kindly come to the dais. At the very outset, I would like to thank the AIOS Scientific Committee for giving us this platform today. And the post-operative day, as we all know, for any cataract surgeon is the most awaited day because this is the day when we get the fruits of our surgery, what we have done. So mostly this is a happy day for us because the patients and their attendants express their gratitude, their appreciation for a surgery that has been well performed. But there is always the fear of the unknown. Significant problems may pop up post-operatively when we least expect them. This IC targets a few such surprises that will actually make us scratch our heads. We have with us today a bunch of eminent cataract surgeons who will be discussing in detail about their opinion on the most intriguing questions after a perfect cataract surgery. We are sure by attending this IC, it will definitely solve several of these post-operative dilemmas that we have in mind for both the novice as well as the expert cataract surgeon. So to begin this session, I would like to invite Dr. Arundhati Tamuli, a prolific cataract surgeon from Lions Eye Hospital, Dibrugarh, to give her valuable opinion on early PCO. How early can we treat? Over to you, Dr. Tamuli.
Good afternoon. Thank you, Jayashree, for making me a part of this instruction course. So, early PCO. Early PCO is also known as secondary cataract or after cataract. Usually, it develops few months to year following cataract surgery. But if the surgeon's luck is bad, he shall have to face an unhappy, anxious patient within few days to weeks following cataract surgery because of this early PCO that causes dramatic reduction in patient post-op satisfaction. So what actually it means? It's the whitening or opacification of posterior capsule following cataract surgery. So patient will again complain of decrease in vision. There may be decrease in the contrast sensitivity. He might complain of glare, photophobia, symptoms similar to that of cataract. And similar symptoms he'll get if we see any other opacity that develops behind the eyeball. So coming to the types of PCO, a classical PCO has two different forms, epithelial and fibrous. If we see in epithelial PCO, the visual disturbance is more. So here, the hallmark of this PCO will get typical pearl-like opacity, which we call Alschnick pearl. Whereas in fibrous PCO, the visual disturbance, comparatively, it is less. And here, what happens, the multiple layer of lens epithelial cell, it becomes opaque and forms the fibrous PCO. This is another picture where we can see, along with the posterior capsular opacity, there is a thick capsular, fibrous capsular band, which may be because of the excessive wrinkling. This is another picture where we can see, along with PCO, there are lots of iris pigmentation, and this is because of the severe post-op inflammation. So with today's technologies and techniques, the incidence of PCO have been reduced. So rather, we can say it's been delayed. So what are the conditions that develop that influences the development of early PCO? So first comes the age. So younger is the age group, more chances of developing PCO. So this is considered the most commonest complication following pediatric cataract surgery. And in infants, we'll see in almost 100% cases, they have a tendency to develop PCO. So what are the reasons that influences the formation of PCO in this age group? So there are multiple factorial which are responsible for the development of PCO at this age group. These are maybe their younger age group, surgical trauma during this early age group, maybe because of the associated surgical management of the posterior capsule, vitreous phase, and many factors. Sometimes this type of pediatric cataracts are also associated with other ocular pathologies, which may be one of the reasons why they develop PCO at this age group. Then second is the rhexis size. If the rhexis size is bigger and completely off the aisles, so what happened, the lens, anterior lens capsular epithelial cells, they comes in direct contact with the posterior capsule. And thereby they produce a alpha smooth muscle keratin, which differentiate into myofibroblasts, and they again leads to opacification. But it's very important, if there is an implant in between these two capsular bag, this will prevent migration of the cell. So it's very important that rhexis should completely cover the IOL. And if there is an asymmetric covering, we'll get severe form of PCO. So there are other factors which affect is the IOL design and the material. It's seen that in today's scenario, majority of the lenses, they are made in a biconvex format, so that the optic surface and the capsule, they remain in close contact, so that they again prevents migration of the cell. Even the square truncated edges IOL also prevents cell migration. Now, there studies have been done which showed that IOLs with hydrophobic surface, the incidence of PCO is less. So eye which has developed severe post of inflammation or uveitis, in those cases also there is 20% chances of PCO formation within first year. Recently there was a study which have showed that the fibrotic PCO formation is more with the flex rather than after phacoemulsification. This is maybe because of the thermomechanical damage to the lens epithelial cell. So these are the causes which influences the development of early PCO. So there are other causes where we may get a retroaisle membrane formation. These are retained lens cortex, capsular plaques, wrinkle capsule, capsular folds, vitreous thread, and the inflammatory membrane. So decision making in this scenario is how and when to treat. So first question comes how. So laser YAG capsulotomy is considered the preferred method to treat PCO and here it's an OPD based procedure, and it is considered the safest because here we don't have to enter into the eye, and here we use the energy level depending upon the thickness of the PCO. Then we have other procedures available like needle capsulotomy. This was practiced in the era prior to the YAG laser. Even it is done in the places where YAG laser is not available. So it's considered little a crude procedure because here we use 26.5 gauge needle, which is passed through the pars plana, and then an incision was made into the thick capsule. But there are sometimes the incision may not be sufficient enough to give to make an opening in the thick membrane. So in that cases, we go for vitrectomy. So another condition where we can go for vitrectomy is the retained cortex if we see vitreous along with the PCO. So now next question comes is when to go for this procedure. So anytime whenever the patient feels there is a decrease in the visual acuity, we can easily go ahead with this procedure. So why actually we are worried to go with this early intervention? So let's see the risk of early intervention. So first is the YAG laser. In YAG laser, we use contact lenses, which may compromise with the wound stability, especially if the wound is large. Second, studies are there which show the risk of cystoid macular edema and retinal detachment following YAG capsulotomy. Then with the other two procedures, needle capsulotomy and vitrectomy, both are invasive procedures, so they have their own potential risk. So now the next vital question comes, can we still intervene in the early post-op period with this procedure? So logically, yes, considering the situation. If there is an absolute indication, definitely yes, we may have to select an appropriate procedure with special precaution. So let's see how we can negate the issues with the YAG laser. So in YAG laser, majority of the surgeons, they use Abraham YAG capsulotomy lens to treat the PCO. But however, we can do it without the use of these lenses. This is possible if it needs a little experience of the surgeon, and secondly, we need little high power. So let's see, this is one of my case where I have done YAG capsulotomy without the use of lens. And I believe many surgeons does this. So here, only thing that we need little compliance from the patient because it takes little time. Only difference is that we need little high power to do capsulotomy without the lenses. Rest is all same. Second is the risk of RD. So there are many studies which have shown that the risk of RD is only 0.5 to 1% following YAG capsulotomy. That too if it is done within 5 months post-operatively. But there are studies which have shown that this risk is similar to the risk which we get following an uncomplicated phacoemulsification. So there is not any absolute contraindication to perform YAG capsulotomy in the early post-op period. So let's see some special situation like in a case of endocapsular hypopyon, which also mimics like a PCO. So in this type of cases, like we usually get a localized, the thing is that we really have to diagnose it. Like we really need to differentiate this condition from the PCO because in endocapsular hypopyon, since it is a chronic infection, post-intraocular, post-surgery intraocular infection, so here the thing is that ideally we shouldn't rupture the posterior capsule because there is a risk of endophthalmitis. Then second is your capsular distension syndrome. This is a very rare complication where the fluids get entrapped between the IOL and the posterior capsule. So in this type of cases, we will get a significant anterior chamber shallowing because there is a displacement of the IOL. So along with the PCO here in this patient, there will be rise in the IOP. So here if we do a posterior capsule, that will solve the problem. So to conclude with that, posterior capsular opacification can be treated efficiently by YAG laser even in the early post-op period without any serious complication. Special and tricky situation, however, need judicious approach depending upon the cases. Thank you.
Thank you, Dr. Arundhati, for that wonderful presentation. So any questions from the audience? Dr. Arundhati, I would like to ask you one thing. Like the report that has stated that flakes causes an increased incidence of PCOS, especially the fibrotic ones where you need a greater number or amount of energy. So what do you think is the actual cause that is contributing to the early PCO in the flex cases? Is it only the thermomechanical damage, or is it because there is only 1 or 2 reports and maybe because of the novice surgeon performing a flex, can that be a condition?
No, that study, it was done in the year 2016. In fact, there was one more study which was done in the year 2018, I think. They have taken, the first, yes, of course, in the first study, they have taken around 60 patients. And the second one, it was quite a large, like I think around 2,000 or 3,000 cases they have already done. So I don't think it's a novice surgeon. And secondly, in both the group, they have said that it's maybe because of exact cause still they cannot define, but they have said it's because of the thermomechanical damage to the lens epithelial cell.
Okay.
And maybe that's what they have said.
Yeah, that is what has been stated
still
actually.
They have to further do the, like, with
I just want to ask you, Dr. Arundhati, like, what's your experience in doing YAG capsulotomy in patients, pediatric patients? And number one. Number two is that how, like you in doing YAG capsulotomy, want to dilate the pupil? That is very important.
Yeah.
You want to fully dilate the pupil, or what is your opinion on that?
So first, like about the pediatric cases you are saying, no, pediatric cases, ideally I try to do a PCC. Because pediatric cases sitting in front of YAG machine is, yeah. And the second question, what you said, like...
Doing the capsulotomy, like what should be the pupil size you like to prefer?
Yeah. So normally, ideally, the pupillary size, like the capsulotomy size, it should be more than the pupillary diameter. The thing is that if your pupillary size diameter and the YAG capsulotomy, that opening, if it is less, there won't be change in the visual acuity. But there are studies which they have shown, like both the photopic and mesopic vision, like especially the contrast sensitivity and the glare, both will get reduced. if your pupillary, if your capsulotomy opening is lesser than your pupillary diameter. So ideally, you should go for a larger
yeah, but one thing is that what I have seen practically is that if you fully dilate, it's very difficult to see the centration of the ear. So if you like mid-dilate it, you can just be just a central opening in the capsule. So that practically, if you fully dilate, is what I have seen for myself. It becomes very difficult to like get that central point of that opening.
Yeah, no, I'm saying the size of the opening, size of the posterior capsulotomy opening. That size should be normal, should be bigger than the normal pupillary diameter, not in the dilated eyes, the normal pupillary size.
Yeah,
Yes,
size
yes,
is there.
size of
But
that
regarding the position which you are talking about, Dr.
Positioning,
Nilanjan, I
yes,
think a
definitely,
semi-dilated pupil definitely gives you a better result, because
Yes.
sometimes you don't know the pupillary position. You do the young opening centrally, and then you see that when the pupil gets constricted, you see that it's not in the central position actually.
True.
So both of this regarding the position and regarding the size. Okay.
I think optimum 5 to 6 mm will be enough.
Yeah, because that size equilibrates to what she has said. Another point, we know that you have put on a lot of multifocal IOLs. So have you encountered any case where you had to take a decision, a patient comes with this photopsia, and you had to decide whether you have to go for YAG, or because back of the mind you know that that patient might require a lens exchange at a later date.
True.
So has there been, do you have any experience regarding this?
See, that's what
This
I'm saying,
deciding
like,
between
to-
PC,
yeah.
whether to go for YAG or whether to go for
See, anyway,
exchange.
if you do first thing especially in case of premium IOL, like multifocal IOL, first you need to evaluate what is the cause of dysphotopsia. It may be because of the lens itself, maybe because of the foveal fixation difference, and maybe because of if you'll do a YAG capsulotomy in the earlier stage, like prior to making a decision, that what happened, the lens exchange becomes difficult. So that is
Okay. Thank you so much, Dr.
Thank you.
Arundhati. So now let us chase another dreaded post-operative complication, the dangling IOL post-operatively. I take this privilege to welcome my good friend, surgeon with magic in his fingers, a brilliant cataract surgeon from ASG Hospital, Kolkata, to present his talk on the dangling IOL. Over to you, Dr. Manas.
Thank you, Jayashree, for the opportunity. And I'd like to thank the audience for staying for the last show. Yeah. So I'll be talking about the management of dangling IOLs. So this IOL decentration can be seen in the intraoperative period, early postoperative period, and also in the late period as well. So let's see first case scenario. This is a young patient with lenticular coloboma with a high myopia. So my aim was to do a phacoemulsification and placing a single-piece foldable lens within the capsular bag and fixing the bag with the CTR and the capsular tension segment. So after doing phacoemulsification and supporting the bag with the CTR and the iris hooks, when I was placing the IOL within the capsular bag, one of my iris hook was too tight, as you can see here, and while implanting the lens in the capsular bag, it got torn at that point. And you can see that the margin got torn here, and gradually it extended to the periphery, leading to a posterior capsular rent with little manipulation. So I just found myself in a situation where nobody would like to be. So the next thing that was going in my mind was, how do I manage the case? Should I go for an IOL exchange with a multi-piece lens? But my bad luck was that That time I did not have the backup of a lower power multipiece lens, and I did not want to keep the patient aphakic as well. So can we fix the same single piece lens to the eye? Whether, well, it can be done whether, to the iris or to the sclera. But suturing a single piece foldable lens to the iris can lead to iris chafing and pigment release. Literature has shown good result with suturing it to the sclera. So I proceeded with suturing it to the sclera. For that I am making 2 partial thickness scleral flaps exactly opposite to each other, and a straight needle of a double arm 9-0 Prolene suture is placed in the anterior chamber, and then a 20 gauge needle is introduced from a distance of 1.5 from the limbus, and it is placed just below the haptic near the optic haptic junction, and the straight needle will be docked inside and will be taken out as close to the optic haptic junction. And similarly, another straight needle will be taken out for this time above the haptic to form a loop, and the same procedure will be repeated from the other side to make a loop out of here. And once it is done, both the sutures ends are tied and little bit of vitreous was there, so I did vitrectomy, and at the end you will see that the IOL is well centered. And this is a 7th picture also. You can see that eye is well formed, IOL well stable. So the lesson that I have learned from this case is that always have a backup of a multi-piece IOL when you are doing this kind of complicated cases, and while implanting the IOL, and if you are using either iris hook or capsular hook, slightly loosen up the iris hooks or capsular hooks just before the IOL implantation. This is another case where in the intraoperative period the surgeon noticed intra PCR and he placed a multi-piece lens, but next day there was gross decentration, so it came to me for further management. And while taking up the case, I thought of dilating the pupil and see whether any capsular support is there or not, so that I can place it in the sulcus. So I dilated and check for any capsular remnant, but support was not that great, so I decided to go for iris suturing the mecanal way. One can also do a scleral fixated IOL in this case because it's a multi-piece lens, and lifting it into the sulcus, and then next I have lifted the optic above the iris to do a optic capture. Here you can see that the optic is above the iris and the haptics are below. So now both the haptics will be sutured with a your 9-0 Prolene suture on both the sides, and both the suture ends are taken out from the same paracentesis and will be sutured in the manner of 3-1-1. So one side is done. Next I'll be doing the other side as well in the similar manner, and at the end when it is done, the knots are cut and IOL is pushed behind. You see that the IOL is well centered and a well formed chamber as well. So to have a round pupil in iris suturing, the location should be mid-periphery. If you go anterior, like near the pupil margin, definitely you will have peaked pupil. Take a shorter suture bites and avoid excessive tightening of the knots. This is a late presentation. Here you can see that the IOL back complex with CTR is decentered both in opposite direction. The primary surgery was done almost 7 or 8 years back. Patient had a subluxated cataract, and the primary surgeon did placed a CTR in the capsular bag, but somehow the IOL was not placed in the bag and it was in the sulcus, and now it has grossly decentered. So any of these kind of primary surgery, during the primary surgery also, the bag should have been sutured to the sclera. So let's see how I have managed the case. My aim was to suture both the IOL and the CTR to the sclera. So for that I made 2 Hoffman pockets exactly opposite to each other, and then the 20 gauge needle is introduced again and a straight needle. Now it has pierced the capsular bag, taking the CTR and the haptic, one below and another will be above. One side done and another, now the other part. Piercing the capsular bag, taking the CTR and the haptic along with that, one below and another above to form a loop. And both the suture ends will be taken out from the Hoffman's pocket and will be sutured gradually. The titration should be gradual so that the IOL remains at the center. And at the end, you can see that the IOL is well centered. Little bit of PCO was there, which been managed with later on your YAG capsulotomy. So this is another case of a traumatic decentration of the IOL. Here also, during the primary surgery, it was uneventful, but the patient had a history of trauma post-surgery, and because of which you can see that the IOL back complex has decentered. Now the haptic is over the iris. So in these cases, thorough evaluation is also important because you never know. I mean, you can just rule out any vitreous is there or not, any retinal pathology post-trauma. So here also I've making a Hoffman's pocket here, and my plan is to suture this haptic to the sclera. Once the Hoffman pocket is made, I have injected dispersive viscoelastic to push the vitreous behind. There was no vitreous disturbance in this case. Similarly, a straight needle will be docked into a 26 gauge needle by piercing the bag. The first needle gone. And now the haptic will be placed behind the iris. Had it been a case of a pseudoexfoliation, I would have sutured both the haptics, but it's a case of trauma. Remaining zonules are quite strong, so I proceeded with suturing with the only one haptic. Now you can see that at the end the IOL is well centered. So this is one of my first case which I did in 2014, and I learned a very important lesson out here. So after placing everything, when I was centering the bag, you can see that both the suture needles are taken out, formed a loop, and when I was centering it, I am trying to center it, and I should have stopped here, but I forced myself to over tighten the knot, and now you can see that the IOL back complex has decentered a lot. So this the important lesson that I've learned is that the suturing tying should be slow and gentle. You should titrate and make sure that IOL remains every time at the center before your final suture knots. So whenever you're managing these kind of cases, make sure that you tighten up your seat belt, because never know when you will end up in turbulence. So in this case, when I was managing this IOL back complex decentration, I passed again the suture loop. When I was centering, I noticed a pre-existing PCR, which was there from beginning, from the primary surgery. So managing these kind of cases is very difficult because I have to suture this part also, and your care should be taken because the back should not get damaged further, because it will be very difficult to manage a dislocated C tear in this case. But luckily everything went on fine and the patient did well. So to have a proper IOL centration, the fixation points should be exactly opposite to each other, and one should have confidence in patients to deal with these kind of cases, because this will take definitely a little bit longer time than your routine cases. Thank you. Thank you for listening.
Wonderful videos, Dr. Manas, and I'm sure definitely all of us have learned something from these videos. I had a question, like in the iris sutured IOL, which you have shown in your second case, how important is it to do a PI? Because you had already done the optic capture. So is there any incidents where you felt post-operatively that, yes, I should have done a PI in this case?
I've done optic capture just before, suturing. So once I have sutured it, I place the lens in the sulcus.
Yeah, yes.
So whenever using a three-piece lens, there is angulation, 10-degree angulation, and when you suture it, the IOL will be a little bit behind the pupillar margin. So unlike when you are placing a iris claw lens, which is very close to the pupillar margin, in those cases you definitely need a PI to prevent the pupillar block. But when you're doing iris suturing, after suturing, the IOL will definitely go a little bit behind, and there will be space for the aqueous to move around, and it will not create your pupillar block.
Okay, so PI is not mandatory.
No.
Okay.
When you're doing iris suturing, not needed. But when you're using a claw lens, it's mandatory.
Okay. And is there any difference that you are using a iris hook for this case, the first case which you have shown? Had the incident been prevented if you had gone for a capsular hook or something like that?
Definitely. I should have gone for a capsular hook, but it was not available that time in the OT, so I proceeded with iris hook. And even then, I should have a little bit loosened up all the hooks, which would have prevented the tear.
Yeah, thank you so much. We have a question.
So did you expand out the CTR after noticing the PCR in the first place?
No. It was there in the sulcus. Luckily, yeah, it's a great concern. Thank you for bringing it out. It was there in the sulcus, and I'm following it the patient almost now. It's almost 4 years now. Everything is okay till now. But yes, there is a chance in future it may go down, or we have to look out. Yeah.
So should we expand it?
No, because now it has gone to the sulcus. You cannot take out a CTR which is there in the sulcus. You will damage everything. So only when it is visible, or it has decentered, or it's in the anterior chamber, or it is somewhere in the retina or somewhere, then you have to take it out. Otherwise, it has gone. When it has gone in the sulcus and you don't see, blindly never try. You will damage ciliary body and all. Yeah.
Yes, sir. On day 2, we have seen this IOL bed complex displacement. So when should we intervene? Like how long we should wait before doing any secondary surgery?
This case I took on the next very day only because there was a gross decentration idea, and if you wait further, what will happen? The lens may go down further. Yeah. So as soon as you have,
day 2 would be fine.
Yeah, if there is no reaction, eyes quiet, definitely you can take it up.
Any precautions should we take before doing the?
Make sure there is no vitreous. In those cases, we usually prefer to give either IV mannitol or oral glycerol to shrink the vitreous. And if there is vitreous, do vitrectomy first, and then go for any suturing technique. Because with the vitreous in AC, you should not.
If cornea is not good, we should wait.
Yes, definitely. If cornea is not good, you should wait. You have to wait. Otherwise, blindly you cannot do. The approach should be like, if you can see the IOL, because when there is SK, when the IOP is raised, you should avoid. I told when the eye is quiet, like cornea is clear, the visibility is good, proceed.
Dr. Manas, do you think vitrectomy is needed, like in all of your cases?
Yeah, in most of the cases, there was no vitreous in the anterior chamber or in the pupillary margin. But yes, while suppose you feel that there is a vitreous in the anterior chamber, we have to do, I have not used triamcinolone, but triamcinolone is good to visualize the vitreous, do vitrectomy, and then proceed.
Because all cases they are dislocated, no? So you never know.
Yeah, but the vitreous was not there in your anterior chamber or near the pupillary margin. Vitreous was not that damaged. The vitreous phase was almost intact.
And in your first case, you have used iris hook, no? So
yes.
What's the need? I have seen a sufficient pupillary exposure. Why you have used directly? You could have given a CTR and then...
Yeah, because I placed the CTR for your equatorial support and iris hook for the supporting the bag for anterior posterior.
Okay.
Because sometimes while you place the lens, if the back complex may tilt, and placing the IOL will be a little bit difficult. So I kept the iris hook just to give anterior posterior support so that the placing will be smooth.
Okay.
Yeah, thank you, Dr. Manas. But I would like to suggest that a take-home message for the beginners who in such cases will definitely to use triamcinolone and go for a vitrectomy, because the experienced surgeon they can know that exactly there is how much vitreous or whether vitrectomy is required or not. But when you're dealing with cases like this, it's good for the beginners that you always go for triamcinolone and go for the minimal amount of vitrectomy that is required. Okay, now we move on to our next stop. Now, what can be more surprising to a surgeon than to see a fixed dilated pupil on the next post-operative day and you don't know how to manage it, it fails to constrict. So indeed, a nightmare for any cataract surgeon. I would like to hereby invite Dr. Swaraj Bhattacharjee from Lakshmi Eye Hospital, Tinsukia, Assam, another wonderful surgeon, a brilliant academician from Assam, to give his opinion on what we should do in such a situation. Over to you, Dr. Swaraj.
Thank you, Dr. Jayashree, and good afternoon, everybody. My special thanks to Dr. Jayashree to include me in his instruction course so that we are in the forum. My topic is fixed dilated pupil after cataract surgery, a nightmare. Normally, just before doing surgery, we are very happy to see the dilated pupil and not the next day. No financial interest, of course. We are all accustomed to see a wow look of the eye next day, but never like this, a dilated eye, pupil. Let's go to a little bit of anatomy. This is the sphincter pupillae muscle, dilator pupillae muscle, which are radially arranged, and sphincter pupillae are concentrically arranged. Where this circular muscle, when they contract, the pupil constrict, and when the radial muscles contract, the pupil dilate. Everything gets jeopardized on the next day, so this is our situation. Now this post-operative atonic pupil that following the cataract surgery, the size of the dilated pupil becomes 6 mm or more in diameter, minimally or non-reactive to the light accommodation, and 1% pilocarpine hydrochloride. Here in this situation, we called it as post-operative atonic pupil or dilated pupil. What could be the issues? There is resulting in glare, poor quality of vision, and definitely a cosmetic embarrassment. Last but not the least, the surgeon's embarrassment. Now, why it happened? It can be caused by very high post-operative pressure due to the retained visco. Increased IOP overnight could damage the iris sphincter, and one finds a widely dilated, non-responsible pupil afterwards. We should remember the very high IOP that should also normally alert the patient with the symptoms of ocular pain and or headache. By the time the patient was seen on the next day, the IOP could have returned to normal, while the sphincter damage is still present. What could be the other cause? Too much of atropine, aggressively dilating regime using atropine or homatropine in cases where the first eye was a challenge to dilate. For achieving the maximum dilatation, the vigorous regime is used, or the fact that the fellow eye has also an unresponsible pupil suggests that perhaps the same sequence of events happens with that eye following surgery, and perhaps there is sphincter damage present there. And very bad, wrongly put in a busy surgical center, really iatrogenic. And toxic anterior segment syndrome or TAS, use of hypromalose as a viscoelastic during the surgery has been linked to the post-operative dilated pupil for no other reason. Iris trauma during phaco surgery can also lead to the dilated pupil. And lastly, Uretz-Javelia syndrome, a definite syndrome that will come into discussion. The fixed dilated pupil after cataract surgery was published long way back in British Journal of Ophthalmology in the year 1993 by Andrew Keketan. Here they have shown that 16.7% of the eyes operated on using hypromalose developed a non-reactive semi-dilated pupil, whereas none of the eyes from the control group developed this phenomenon. It was also noted that the iris of the patient with the fixed and semi-dilated pupil showed the presence of generalized sphincter atrophy, but there is no evidence of sphincter rupture. A few points about the Uretz-Javelia syndrome. Here we get a fixed dilated pupil, iris atrophy, and the inflammatory reaction, which usually happens following the intraocular surgery like phaco, phakic IOL, trabeculectomy, DMAC, DSEC, DLK, and penetrating keratoplasty. UJS will typically occur 1 to 2 weeks after the intraocular surgery. We like to have an unusual case presentation which was come in the post-operative 2 weeks. There was visual discomfort suddenly, bothersome glare at night. On examination, anti-HMI inflammatory reaction 3+ with the no fibrin or hypopyon, and no further findings were found in the examination, which was increased with the increased dose of steroid and has improved to some extent. In the next 1 week, something happened. AC reaction become 1+, pupil become fixed and dilated with no response to pilocarpine. There was a diffuse iris atrophy. Pigment was found in the inferior cornea and the lens, mainly on the inferior capsular axis line. Gonioscopy shows a closed angle. Other eye has got an open wide angle, and fundus and IOP is within normal limits. Here in this photograph we can see the pigment cells in the inferior cornea and the lens, mainly on the inferior capsular axis line. And the gonioscopy closed angle except on the nasal side and peripheral anterior synechia. present. Interesting finding was that the cataract surgery was done. 2 weeks later, there was inflammatory reaction, and after 1 week, there was development of UGS. The possible risk factor for a delayed inflammatory reaction include TAS, endophthalmitis, residual lens matter. Recent research shows that the progression to the secondary glaucoma is reportedly observed in approximately 1/4 of the cases. Although it should not be considered as a definitive characteristic for the syndrome, it is important that IOP should be monitored following these cases. The potential treatment should be treatment of the inflammation and IOP rise, if any, use of the pilocarpine usually ineffective if the sphincter is damaged, and surgical treatment includes the pupillary sarclage and single pass 4-throw pupilloplasty. What is pupillary sarclage? Wherein multiple paracentesis opening are used to access the iris. The pus busting or whip stitches evenly spaced along the pupil margin, tied with an intraocular knot to produce a smooth round pupil. But different steps, we're just pulling off with the micro forces, pulling on the iris and using a needle, Prolene needle, 9010 Prolene needle, and making a stitch like this and taking out through the clear cornea. In the second part, again introducing from the other end through the clear cornea and continuing the same process and taking out through the clear cornea. The second wound has been made, the second suture, and then the third suture is being in this direction, and then pulling off both the end, making a whip stitch over there, and ultimately the pupil comes to this stage. Secondly, I like to present a video of Dr. Amar Agarwal. We are pulling on this is an animation. We are using 9010 Prolene suture. This is just for the accounting interest. 26 gram needle is through. We do a railroad technique. Pulling off the other end of the suture and make a first, second, third, and then the fourth throw pupilloplasty. I have borrowed this video just to show, and both ends of when they are pulled, a very beautiful pupilloplasty develops. On this side, this is repeated on the other side. With a micro scissor, this has been cut, and we get a very beautiful pupil. This is the video demo. I think by now we have seen this 4-throw pupilloplasty in many of our videos. This is the first pupillary snap. Second part of the pupilloplasty. Pulling out, giving a 4-throw, and by this time the pupil become constricted. In the last part, the iris is being pulled, but before that, please take care of the iridodialysis. So what are the take-home points? Use of the preservative-free intracameral drugs are preferred. Maintenance of fluidic to avoid the anterior chamber turbulence. So far as possible, we should do in a lower parameters, and proper and adequate cleaning of the visco, which is very, very important. Thank you so much.
Thank you, Dr. Swaraj, for that wonderful presentation. Yes, and a very good take-home message to avoid the turbulence in the anterior chamber whenever we are doing any case, and not to take this case lightly, because it might be that sometimes you never got to see such a case, but once you get such a case, it becomes very traumatic for both the patient as well as for the surgeon. Now, this condition actually arises, mostly in a busy OPD where you don't see all your cases, and you might sometimes miss even a case of traumatic mydriasis, which might might have pre-existed and you didn't know, and then you have, suppose you have a case like that, a case of traumatic mydriasis, you operated upon the case without knowing that the pupil did not constrict even pre-operatively. You thought it was a pre-operative preparation that produced a pupillary dilatation, and you went ahead with the case. So what now? What next?
You have to be very careful. We will try to see the take-home message. We must say at least we must give some chair time to the patient. That is very important. And once it happened, then I think we have to follow all these procedures.
Yeah, pupillary circulation.
Yeah,
Yes.
that to be done. It can be done. I have done in one cases, but no video. But it was not that cute.
Oh.
Not to be presented. But I tried actually.
Okay, honest confession actually.
Photos were very cute, but.
One thing, like if the patient already had traumatic mydriasis and he has come for the cataract, he'll not complain of that post-op thing because he already suffered.
Yeah, and he will have this glare. He won't feel it.
He is
By the
just
time
accustomed to the glare.
neuroadaptation is
Yes,
there.
yes, and he himself will tell you that I am having this.
Yeah.
Recently, I got a patient, like, he didn't have any cataract, but he is like, no, I have gone to many doctors, they are all saying it's because of the trauma. Ultimately, we did a pupilloplasty and he became okay. It's not because of the cataract. Like, they already had that thing in their mind.
Yeah,
Exactly, but the patient does not confess to you before surgery, and then they come with, they expect that you correct that part also. So thank you so much, Dr. Swaraj.
Thank you. I think is our chief instructor, Dr. Jayashree Barua, on the stage. She is a prolific surgeon, academician, and as well as a good orator. We are proud of you. Please.
Thank you so much, Dr. Swaraj, for those kind words. And now I'll be talking on challenging the limits of post-cataract surgery, dry eye. Now, these were the situations that we had seen some of us might have encountered and some of us might not have encountered. But this is a question which each and everyone needs to tackle someday or the other. When the patient comes to you and tells you, yes, doc, I am having discomfort in my eyes, there is irritation, there is foreign body sensation, it was not there before my surgery. So what do we do now? And the patient keeps on repeating the same complaints again and again. So how important is it to include the post-operative management of dry eye in our post-operative protocol? So we are talking about the condition where actually our treatment has become a trigger, because cataract surgery can independently, transiently induce or exacerbate a pre-existing dry eye condition. So a notable addition to the TIFA's DUCE 2 report, which included the term iatrogenic dry eye disease as the cases of dry eye that has been caused by our examination or our treatment, be it the medical treatment or the surgical treatment. So this is the classification of iatrogenic dry eye in which cataract surgery plays a very important role. Now, when there was an analysis about the status of the dry eye in surgical practices, it was noted that most of the ophthalmologists actually they went ahead with the corneal staining and the tear breakup time before surgery, and this is a good result. The results published by Tretler et al., the FECO results, which indicated that 81% of the patients that we take up for cataract surgery actually have a pre-existing dry eye condition. Now this post-operative dry eye, post-cataract surgery, it fluctuates from 9.8 to 34%. And according to the ASCRS report, which came out in 2015, it stated that the dry eye disease prevalence was around 40% in the patients who underwent cataract surgery. The entire cascade, it revolves around a few factors that are the tear film instability, tear hyperosmolarity, leading to the production of the inflammatory mediators, which alters your lacrimal secretion and the blinking, and this cascade is repeated. So to manage a case of dry eye, we have to stop this cascade at some point or the other. So we have three subsets of patients exactly when we are talking about post-cataract surgery dry eye. We have a set where you have diagnosed the dry eye pre-operatively and you have started the management protocol beforehand and you are continuing it post-operatively. You have another set where you might have missed the dry eye condition pre-operatively, and the third subset is where the dry eye has actually developed after your cataract surgery. So this is an algorithm which shows how to manage a case of dry eye. This is altogether a different topic where how we should include it pre-operatively. But the main factors that are responsible in our post-cataract dry eye disease are the damage to the corneal nerves along with the ocular surface trauma. This trauma may be in the form of the microscope light we are using, it may be in the form of medications we are using pre-operatively, or repeated irrigation of the corneal surface while doing the surgery, or the surgical trauma itself. So the four main ocular surface changes that are responsible for dry eye is your desiccation, your epithelial damage, a short T-bud, and the friction. Now in post-cataract surgery, you have the nerve damage which reduces your corneal sensation, so it decreases the feedback. There is disruption of the corneal lacrimal gland loop which reduces the tear meniscus, and along with this you have the inflammatory changes, you have the surface irregularities at your incision site which is also giving rise to dry eye. Now this corneal denervation, when you are doing an extracapsular surgery, it lasts up to 2 years, and in phacoemulsification it is 3 months. And the corneal sensation and the T-bud both decreases. When you're doing a smaller incision, say a 2.1 mm incision, it returns to baseline within 1 month. But when you're using a wider incision like a 4 mm incision, then it takes approximately 3 months to regain its normal stature. So post-operatively, there are two changes that are occurring at the corneal level. You have a significant increase in the central corneal thickness, which increases from the first post-op day. And from the third post-op day, what happens is that your corneal epithelial thickness, it tends to decline, it tends to come down. And this process continues till the 14th day post-surgery. There is quick tear film breakup that is observed post-cataract surgery cases, and also there is reduction in your meibomian gland function as well as the expressibility. It reduces the viscosity and the tear film stability, leading to decreased lubrication. So there is increased friction which the patient complains as your foreign body or irritation. So how meibomian gland function is altered by phacoemulsification is not exactly known, but it is believed to be due to lead dysfunction that is caused by using the speculum. It alters the congruity and the dynamics between the lead and ocular surface, decreases the blinking rate, the topical medications we are using, and the surgical procedure itself. And flex is to be more, it causes more fluorescent staining and higher incidence of dry eye symptoms as compared to a conventional phaco. But be it a conventional phaco or flex, it both causes a decreased T-bud and the Schimmel's 1 value. Now the main part of the topic today is recommendations for preventing and reducing dry eye disease related to cataract surgery. So pre-operatively, we should avoid using the preservative in the eye drops, and we have to optimize the ocular surface before actually taking up the patient for surgery. If required, delay or postpone your surgery till the ocular surface is managed. And if you notice that there is any keratometric, any topographic alterations pre-operatively, then that may be an indicator that yes, your patient is having a dry eye pre-operatively. Now, intraoperatively, you have to choose a technique that has a shorter surgical time, a smaller incision, and you avoid persistent irrigation of the corneal surface. You limit your microscope light exposure as well as the intensity. And when you're going for the anesthetics and mitretics, it can be a good practice to go for the intracameral injections instead of going for repeated topical installations. We have to be very careful when we are treating our patients who are on the premium IOLs and even the flex patients. And post-operatively, again, avoid the epitheliotoxic drugs as far as possible. And you have to choose a proper treatment to restore the ocular surface and increase the frequency of the post-operative visits. So currently there is no prophylactic treatment or drop that can be labeled as something that prevents your post-operative dry eye. So active screening and evaluation of these cases and patient education plays a key role. And you need to choose a therapy based on the type and the severity of dry eye condition. So how do you incorporate dry eye into your surgical protocol? There are 3 models of management. First is the integrated model, where your dry eye management is an integral part of a preoperative workup. Second is the delegation model, where in a busy OPD, it's your optometrist, maybe your associate, who is looking after these conditions, the preoperative protocol, and before the patient actually reaches you, this part has already been managed by them. And a comprehensive model, you can go for this model also, where all the patients undergo a battery of tests so that you can vividly, you can deny any case of dry eye pre-operatively. So regarding the treatment options, definitely the first line of management are artificial tears. Fortified artificial tears have the added advantage. The lubricants, the gels and the ointments, they cause some blurring of visions, and our post-operative patients are already on steroids, and mechanical blockage of the drainage system may be required in some cases. No financial disclosure regarding this slide, but just one point about this newer medication, the sustained hydration, which has the unique formulation of HPGOR, sodium hyaluronate, boric acid, and PGs. What it does, all the 4 ocular surface changes that I have mentioned, it tackles all the 4, like it provides hydration, your epithelial regeneration, augmented protection, as well as lubrication. So to summarize and to simplify the ocular surface optimization, if you don't have any ocular surface issues, you can go ahead with the surgery. But if there is any meibomian gland dysfunction or allergy, you treat it beforehand. If there is aqueous deficiency, the first line of management is the artificial tears. Gels may be required, cyclosporine and the omega-3 supplementation. This doesn't work, you can go for the low dose steroid and the lower plugs. And in the last resort, you have the upper plugs and Lipiflow. Now, what is Lipiflow? This is an FDA-approved treatment for meibomian gland dysfunction, where what you do, there is warming and massaging of the inner surface of the lids. So it helps to restore a healthy oil production and also improves the tear quality. And this is very helpful in the baseline cases of meibomian gland dysfunction, which you might have missed incidentally pre-operatively. Thus, to conclude, it is the surgeon's awareness of the risk of post-operative dry eye disease and the patient education that is very important in this condition. Quoting what Donnerfeld has said, that if you diagnose a dry eye prior to surgery, it is an expectation. But if you don't diagnose it until after surgery, you have made a complication. So appropriate and tailored therapy for the ocular surface is very important, and ensuring a good quality tear film in the post-operative period is instrumental and should be the standard of care after every cataract surgery, like we do in our refractive surgery cases. Thank you so much for the patient listening.
In dry eye patients, doing cataract surgery is also very challenging, because after surgery also the dry eye problem increases.
It increases, yes, definitely. So as I have told in the take-home message, maybe it's a good practice that because you don't know which are the patients who will come to you. Patients might have irritation, they might not complain to you. Patient might have a minimal irritation, they might complain to you. So like in our refractive surgery cases, why do we go for a tear substitute? Because you are again dealing with the cornea. No doubt that the corneal incisions and the corneal cutting which we are doing in refractive surgery is more. But even in a phacoemulsification, it's not less. You have on an average 2.8 millimeter, or it may extend it to a larger size. You have 2 side ports, or maybe 1 side port or 2 side ports. So the amount of corneal nerve injury that we are doing is not less. So it can be a good practice, like instead of adding other medications, you can give an artificial tear substitute, just a basic artificial tear substitute to the patient. They'll be quite happy. Yeah, these cases are important because as I have mentioned, like in case of when we are doing the cataract surgery, even the speculum, using the speculum, it also squeezes out and expels some of the meibomian secretions which were not there pre-operatively. So it's very important to manage such cases, like post-operatively you go for you again explain to the proper lid hygiene to the patients. You cannot use the squeezing too much in those cases because the patient may actually cause harm to your lenses, but going for a higher and 45 drops may be helpful in such cases. And wait till, give a sufficient amount of time. It's said that you wait for 7 to 14 days till before you actually start with your active procedures, so that you give some time for your incisions to heal, at least a 7 weeks gap.
So we can start the lid massage or Lipiflow after 15 days?
After it said 7 to 14 days, we can start that, but not before that, just because the patient is going to handle it. You are not going to do the massage. Yeah, exactly. Yeah.
Madam, what is your opinion about wiping of the lid? Nowadays wipes are coming up. They are asking that what is your opinion about it?
I am in favor, personally, I am in favor of the wipes because, even how much so you explain to the patients, there is some amount of increased lacrimation that occurs post-surgery, be it because of your dry eye or be it just the after effect of your surgery. So the patients, they have a tendency, even if you tell them, they'll wipe it with something else. So instead of going for wiping, but it has its own pros and cons. Like in the Indian subset, we have an idea, you are buying it's a huge strip that comes. So reusing the strip is not allowed, but one-time use of that is better than using your cloth. It's better than using the cotton that you get from the pharmacy, or it's better than rubbing with your hands. So personal opinion is that I'll go ahead with the sterile wipes, just for one-time use, not tearing it and use repeatedly, avoiding the Indian mindset. Yeah, sure.
Do you think a dry eye can cause actually change in the keratometric reading and lead to a IOL power miscalculation?
Yes, definitely. As I have mentioned, and it's a good indicator that you repeatedly get a wrong. And one important thing is the ocular surface. You can analyze it by instilling the eye drop. Like you had a keratometric reading, you had some doubt, you instill just the artificial drop and see again. If you see there is any discrepancy, you are sure that there is some dry eye problem with this patient.
And then maybe you would like to treat it for
Treat it, yeah. Then repeat it. Yeah, exactly. Thank you so much.
Jayashree, in case of very severe dry eye, these are the patients who are having chronically dry eye. So how do you suppose a dry eye patient with a total cataract or something they want to go for the surgery also, they're having severe dry eye also. So how do you actually go with this type of patient? Like even the keratometry, she said it will be a difficult problem. Okay, now in this type of patient, how you proceed?
See, when we are talking about the total cataract or a mature cataract, the patient has already been he has been living with this cataract. Cataract is never an emergency surgery that today you get a medcat, you have to operate it. It's not like that. So what is more important is his satisfaction post-surgery. So it's better that he had stayed with that cataract for some time. Let him stay for another 7 days, but at least you'll give a good result post-operatively if you treat his dry eye condition beforehand.
No, these are the patients they are suffering from chronic dry eye. They have been taking medicine for long, and you are not able to treat.
Yeah. Still then we'll go for a 7 to 14 day regimen so that we'll try to stabilize, to optimize the ocular surface to a basic level before we can actually proceed with the surgery. Because a severe dry eye patient, you are not going to take up that case for cataract surgery without doing it without treating him preoperatively.
So do you want to go for some extra procedure like a punctal plug or?
Yeah, definitely. But these are the management for the severe dry eye cases. Mm-hmm. Definitely we need to go for the treatment as per the protocol. But treat his dry eye, ocular surface management has to be done before we actually take up the patient for surgery.
Ma'am, is SICS with single corneal, this is sclerocorneal tunnel without making any corneal incisions? We can minimize the dry eye without interfering with the cornea.
See, there is exactly no study as such, but somehow if you see the incidence of, there has been studies that has been reported regarding the incidence of dry eye post clear corneal incisions and post scleral incisions. And it has been seen that when you make a sclerocorneal tunnel, even though the length of the incision is more, because the damage to the corneal nerves internally is less, so it causes a fewer incidence of dry eye disease as compared to a phacoemulsification where we are cutting the cornea through and through. So the amount of damage is more. So it's just a relative study. There has been only one study reporting that, but definitely it's incidence or the patient, and you have an explanation to the patient. Actually, what do we say when a patient of dry eye comes to us? We tell that you are filling the incision, but actually it's not filling the incision. It's the corneal nerve damage which is responsible for the irritation that the patient is complaining of.
Can we take some steps to, in surgical steps to reduce the dry eye incidence?
Just as I have mentioned, repeated anesthetics, mydriatics is not allowed. Patient is not dilating. You are doing under topical. Don't go for repeated installations. Go for intracameral. Reduce your exposure time to the light under the light microscope. Reduce your surgical time. Reduce your incisions. So these are the factors that will help you definitely. Thank you so much. So our next talk today is on post-operative CME, a cataract surgeon's dilemma. To present this talk, we have with us here today Dr. Nilanjan Kaushik Thakur from Silchar Medical College and Hospital, Assam, a wonderful teacher, a prolific surgeon, and he'll definitely enlighten us about this situation. Over to you, Dr. Nilanjan.
Thank you so much, Dr. Jayashree. I'll be talking on post-operative CME, a cataract surgeon's dilemma. So this is actually a 58-year-old patient who presented with complaints of blurring of vision in the right eye 1 month after an initial post-operative improvement following an uneventful phacoemulsification surgery. Now his BCVA was 6/18, anterior segment and posterior segment showed no abnormality. So we did an OCT post-operatively, and after 1 month that when he came for the complaint, and we found cystoid macular edema. So this pseudophakic cystoid macular edema, or PCME, is broadly defined as the accumulation of excess fluid in the extracellular space of the neurosensory retina, presenting clinically with cyst-like spaces and abnormal thickening of the macula. It is also known as Irving-Gass syndrome. So pseudophakic cystoid macular is the most common cause of less than expected post-operative visual outcome after cataract surgery. So you'll be very frustrated. So you've done a fantastic surgery. So coming to the incidence, actually clinically PCME in phaco can go up to 2.35%, flax 1.18%. But if you do an angiographically it will be very high, PCME. So the pathophysiology is multifactorial. It can be inflammation or vitreous traction. So once there is manipulation in the anterior chamber, so there is release of arachnoid acid from the uveal tissue. So this arachnoid acid causes release of prostaglandins, leukotrienes that diffuses posteriorly, and they disrupt the blood-retinal barrier. So once this blood-retinal barrier is disrupted, so there is leakage, extravasation of fluids, proteins into the retinal interstitium and extracellular spaces. So that alters the oncotic and the hydrostatic pressure, and ultimately more fluid is drawn. Okay, so now coming to the causes. So we have to be careful in patients with diabetes, elderly, hypertensive, but the important causes are the surgical. Now it has been proved that the integrity of the posterior capsule is perhaps the most important factor for the development of PCME. Number two, it is seen that PCME is seen more in complicated cataract surgeries. Number three, if there is disruption of the anterior vitreous phase, there is development of aphakic CME, and this has been proved histopathologically. So another thing is that you are having an uneventful cataract surgery. Patient comes to you after 1 month with a PCME, and it persists for a longer period of time. This is very frustrating. So there are a lot of hypotheses. One is that there may be an underlying genetically determined immune variation that predisposes to inflammation in response to presence of an intraocular lens. So now coming to the diagnosis. How will you diagnose? It may be by clinically or by imaging. Clinically, the main complaint is the history, the vision drop, the drop in the vision. So that is the first indicator, and onset is generally at 4 to 12 weeks after surgery. You have to do a slit lamp biomicroscopy. You will definitely see dull foveal reflex and the typical honeycomb appearance of the macula. Now coming to the interpretation with imaging, the most important now is the OCT. So OCT will, as you see in the picture, will show a triple layer edema. So there will be edema in the inner nuclear layer, the outer plexiform layer, and the subretinal space. If you have any confusion, go for an angiography. Early phase will show leakage in the peripheral capillaries and a typical petaloid or flower petal appearance in the late phase. You can go for OCT angiography, which will show alteration of the deep capillary plexus. Now, though we are cataract surgeons, you should, by seeing an OCT, should have some idea about Pcme and Dme. So Pcme, there is a triple layer edema involving the inner nuclear layer, outer plexiform layer, and the fluid in the subretinal space. So, and the retinal volume is very high, and in Dme, there definitely the history of hyperglycemia. You'll see hard exudates, but subretinal fluids collection is rare in Dme. Now, as a cataract surgeon, you should be very careful in patients with uveitis and also in diabetics. So proper workup is very, very important. Now coming to the management part. See, spontaneous resolution occurs of the CME in 80% of the patients, okay? So most surgeons prefer uses of combination of topical steroids and NSAIDs for the management of PCME. So here are some of the topical NSAIDs which you can use. They inhibit the COX enzymes. Now there are a lot of studies. They've compared various topical NSAIDs, and they found that all the NSAIDs reduces the macular thickness, but neither drug was superior than the other. Okay, so these are some of the studies. So this study compared bromfenac and nepafenac. Both reduces the macular thickness, but nepafenac sustains for a longer period of time. So you can go for steroids like lipophilic prednisolone or water-soluble dexamethasone. So steroids, you all know, stimulate the production of lipoprotein, which inhibits the phospholipase A2. So most important is the persistent and refractory CMEs, which doesn't go away. So you have to go for periocular steroids like subtenon injection or triamcinolone acetonide. So this is a must in a patient's CME with due to uveitis, okay? And you can go for intravitreal steroids like triamcinolone or dexamethasone implant. So these are used nowadays. And there are a lot of studies which have advocated uses of intravitreal anti-VEGF. Vitreoretinal surgeons will tell much better, give much better light on that. But I have seen that the studies have showed that repeated injections did not result in better outcome in anti-VEGFs in PCMEs. So if you are having a vitreomacular traction and you suspect a VMT, refer it to a VR surgeon for surgical intervention. So another important part is the prevention. So how will you prevent PCME? So now the studies have shown that definitely if you use topical NSAIDs preoperatively, it reduces the PCME postoperatively, but there should be a risk factor. So that is all the studies have shown that there should be a risk factor like diabetes and all. So then the topical NSAIDs works very good if you give preoperatively, okay? So these are the studies. So in our case, what we did, first we did after the patient's visual acuity was assessed, we did a slit lamp biomicroscopy, then did an OCT, then started the patient on topical steroids prednisolone and tapered it for 1.5 months. Then we started on topical nepafenac eye drop for 3 months, okay? Then after 3 months, we saw that there was an improvement of 2 lines. BCVA was 6/9, and which was documented with an OCT. We found reduction of the cystoid macular edema. So there is no clean-cut guidelines actually. I have seen lots of things. This American Academy of AAO also guidelines I have seen. So the take-home message is that first-line treatment is always topical steroids and topical NSAIDs. In case of refractory and persistent cases, go for intraocular steroids, or if you want anti-VEGFs, and if you feel that there is vitreomacular traction, refer the patient to a vitreoretinal surgeon. Thank you so much.
Thank you, Dr. Nilanjan, for that wonderful talk. I would like to know that whether you include NSAIDs in all your post-operative cases, or as you have said, only restricted to the cases having risk factors.
Personally, I use in my all the cases I use it definitely. But when I was going through all the studies, many studies have shown that they work good only when there is a risk factor associated with it, like diabetics patients and all. So a lot of VR surgeons are there; they can also highlight. So these things, but personally, I'm going for NSAIDs.
And any issue with the tolerability issue with using NSAIDs post-operatively in your patients?
Actually, see, one more thing is that NSAIDs and most of us use topical steroids also. So it's of no, I think when there is no risk factor, means if you don't see anything like that, so don't go for both the drugs for a longer period. You can go for topical steroids only. NSAIDs, you can stop it. Because NSAIDs will help you in mydriasis also in little bit of preoperatively plus that also.
Okay, thank you so much.
Thank you.
Any role of preoperative NSAIDs? I mean,
That's what I was speaking about. Preoperatively,
Diabetic.
actually, personally, I use 1 day or 2 days prior to the surgery. But when I was going through the literature, they show that if you don't have a risk factor associated, and the role of NSAID is doubtful, topical NSAIDs, but definitely works good when you're having a risk factor like diabetes and all.
Dr. Swaras, what is your opinion regarding using NSAIDs preoperatively or postoperatively in all our cases?
24 hours I used to give, and the bottle
Preoperatively.
preoperatively, and the first bottle that has to be completed.
Okay.
No point wasting also in that point.
Okay.
But nowadays, NSAID is coming up without preservative also. That is one of the good side. Yeah.
Okay. Thank you so much, Dr. Nilanjan. So next we come to our last talk. We have a young dynamic surgeon from Nalbari Eye Hospital, Dr. Mayur Bhorali, who will now throw a light upon the most dreaded, what we all fear, the post-operative red eye. Is it a toxin or bug? Over to you, Dr. Mayur.
Thank you, Dr. Jayashree, for giving me this opportunity to speak on one of the dreaded. We can say once it is endophthalmitis or something vision-threatening causes, but the screen, भैया नहीं दिखाई दे रहा है? हाँ, भूलना नहीं. Yeah, so post-operative red eye, whether it is eye, toxin or bug. So after uneventful surgery, we are happy to see these type of photographs or patients on the slit lamp, clear cornea, PCIL in center, there is no striate keratopathy, round regular reacting pupil, and we are happy, patient is happy. But not always post-operatively we do get these type of pictures also. A red eye may be due to very harmless subconjunctival hemorrhage, or maybe it can be due to the vision-threatening causes of TUS or some sterile infections, or due to infective causes also, the dreaded one, that is the endophthalmitis, where suddenly the good patient behavior becomes changed, they become aggressive. Sir, मुझे दिखाई नहीं दे रहा है. Though with a red eye subconjunctival hemorrhage, he can have a 6/6 vision. क्या problem? मेरा आँख लाल है, I cannot see anything. His vision is 6/6, but because he can see his red eye, his family members can see red eye, they think that something dangerous has happened. So in this era of advanced technology in cataract surgery, still we do get this unhappy patient with 6/6 vision, maybe due to redness primarily, pain, foreign body sensation, itching, watering. But today I'll talk about red eye, what can be the causes. So while it may be a cause of concern for the patient, but it should not be a cause of concern, but it should ring a bell to the surgeon that we have to rule out the causes of red eye. So all red eye post-op should be first of all suspected to be due to bug or infection, unless proved otherwise is the dictum. We should always be safer than be sorry later. So it can be presented in the first day post-operative to the first week, or maybe 2 to 3 weeks later, and as late as 6 weeks also. But here the early diagnosis is the key. Because timing is everything in case of if we go for the dreaded complication of toxic anterior segment syndrome or maybe endophthalmitis, both can cause vision-threatening causes. So, but the normal causes, we have to think the normal first, that is the subconjunctival hemorrhage. It can occur during the injury with a drape cutting, or due to pressure with the speculum also it can happen. It was more common with the small incision cataract surgeries, but nowadays with phacoemulsification, the subconjunctival hemorrhage is late, and this what happens is that during the surgery you have injured, by the time patient reaches his home by 2-3 hours, this subconjunctival hemorrhage increases the whole eye, and then patient fears. Then other causes of the red eye can be the intraoperative medications like that increases the risk of medicamentosa or toxic keratitis due to the use of multiple drugs, and they are exacerbated in the presence of dry eye, or maybe post-surgery dry eye also exacerbated. With the preservative containing drugs, use of preservative containing drugs, use of providone, iodine, etc., that can cause a red eye also. Then corneal surface injuries with instrument keratome choppers, this can cause all causes of red eye post-operatively. Tear film breaks, then post-operative IOP rise can present as dry eye, and finally the more vision-threatening causes of post-operative inflammations, TUS or endophthalmitis. Another cause is a rebound iritis following cataract surgery. That is when we start tapering the steroids. Maybe an eye normally used for 20 days, the steroid antibiotic combination, and sometimes the patient but many surgeons use prednisolone acetate for 1 month, 1.5 months, but when they start tapering it, it can also cause rebound iritis causing a red eye. So maybe specific causes is due to the poor compliance. Sometimes patient stops from by themselves without waiting for the directions. Improper response of the eye itself can cause improper response to the eye itself to the standard tapering mechanism. And sometimes also lens matter are there in the angles and they can cause those rebound iritis. So post-operative inflammation now towards the vision-threatening causes. That is, with the increase in the cataract surgery rate, surgeon must be prepared to handle most the prevalence of complications also. The complication can be the toxic anterior segment syndrome, endophthalmitis, both present with the same symptomatology that they occur early post-operative period with decreased vision, redness, and pain. So few lines about TAS and endophthalmitis, because they itself they are big topics in itself, and instruction course on these topics can be made, but I'll just touch few of the points. So toxic anterior segment syndrome is a sterile postoperative inflammatory reaction. It is due to the non-infectious substances entering the eye. So what is the characteristic is that there occurs very early, 12 to 48 hours. They are gram stain, culture negative, usually improves with steroid treatment. So what is the situation that can lead to TAS? That is inadequate sterilization of the instruments, enzyme, detergent remaining on the cleaning of the instruments, endotoxin contamination during the instrument sterilization, then preservative product from the medication used intracamerally. So sign and symptoms of TAS include the hypopia and fibrin formation in the anterior chamber, corneal edema, where limbus to limbus corneal edema is the clincher and a fairly specific and dramatic finding. Then an anterior chamber reaction is severe with iris ischemia causing fixed pupil. So prevention of TAS is a environmental and toxic control issue, because it's not in our hands. Sometimes the sterilization part, how your staff is sterilizing the instruments, what are the drugs we are using intracamerally. So prevention of TAS primarily depends on using appropriate protocols for cleaning and sterilizing surgical instruments and paying careful attention to all these things we used, medication, ophthalmic devices, etc. So key points, it's a rare complication but not an uncommon complication of cataract surgery which presents at a red eye. Then prognosis is generally good and management involves intensive topical corticosteroid therapy and management of IOP. The prognosis is good, but it can sometimes lead to corneal decompensation or intractable glaucoma or CME also. Next, lastly, the most dreaded complication we all fear, that is endophthalmitis, which presents as a red eye. So it's a rare but serious postoperative complication of cataract surgery. It can have a devastating consequences not only on the patient but on the surgeon also. It feels like why you have done the surgery and whole career is finished if you get one endophthalmitis. But you have to manage it well, then it is okay. So endophthalmitis is an inflammatory reaction of the intraocular fluids due to an microorganism entering the eye. Sign and symptom develop usually begin 2 to 10 days post-operatively, as late can 6 weeks also, and present with redness, deep ocular pain, decreased visual acuity, etc. The primary cause, source of intraocular infection is from adnexal structures or cornea, conjunctiva, lacrimal glands, eyelids, etc. Symptoms occur 1 week post-operatively in 75% of cases, with present with decreased vision, red eye, pain. On examination, the eyelids are swollen, hypopyon is present. These are telltale signs of endophthalmitis. So numerous fungal and bacterial agents can cause post-cataract surgery endophthalmitis. Most commonly, it's a gram-positive, coagulase-negative staphylococci, followed by Staphylococcus aureus, streptococcus, fungus, and then your gram-negative organisms also. So it is a clinical diagnosis and is supported by test, culture, vitreous step, B-scan, ultrasonography. Prophylaxis against the endophthalmitis has evolved extensively, but mainly we all have to do the lid hygiene. Use of provident iodine is I think it is the only proven thing to prevent endophthalmitis, both pre-operatively, intraoperatively, and personally in my all cases I give a 1 drop of provident iodine post-operatively also. Then intracameral use of antibiotics. This is also a contested thing, I guess. Not all surgeons use, but we should use intracameral antibiotic, and mostly it was after this study by Arvind Eye Hospital also, they have emphasized the use of intracameral moxifloxacin in decreasing the endophthalmitis. Then management of PCR or any intraoperative complication, because they can also increase the risk of endophthalmitis, construction of watertight wounds, etc. The differential diagnosis is your sterile intraocular inflammation, toxic anterior segment syndromes. Management includes intravitreal administration of antibiotic, which is the considered fundamental step. And finally, with the advent of more advanced vitreoretinal surgeries with pars plana vitrectomy, core vitrectomy, is a gold standard of treatment in case of fulminant or refractory endophthalmitis. So finally, the take-home message is when we see a case of red eye, हमको घबराना नहीं है, but we have to manage the case, and management of the case of a red eye is most important. To summarize, post-operative red eye is a common finding in uneventful surgery. Early diagnosis is the key, but ruling out early management, early treatment go a long way in saving the vision. Thank you very much.
Okay, thank you, Dr. Mayur. Suppose you're in a setting where you don't have facility for B-scan or facility for culture. How will you proceed with such a patient in such a situation?
This is a very common problem with most of the surgeons, because they don't work in an institute. They work in periphery hospitals, and they don't have, because in my place only, I have one microbiologist who don't want to do culture also. More than 50-60 kilometers away, there is a VR surgeon. So first, we don't have a B-scan also. In these cases, because endophthalmitis is a clinical diagnosis, so your clinical acumen is must. And till how long you want to wait? That means timing is very important in case of endophthalmitis. So still, you should have a good VR friend with you and your clinical acumen. And if possible, if you suspect endophthalmitis, we should not fear to give an intravitreal injection of at least the first antibiotic dose, and then send the patient to the VR
That's
surgeon.
what is
That
important actually. Whenever you have the suspicion, don't just let it go that it might not be, because the thing is that it might be endophthalmitis. And you have 30 to 40% of the patients where it is endo, but it's culture negative. So you don't know, that confusion always exists. So it is better to go towards infection rather than going towards
less harm if we give a...
Yes, exactly. Okay.
I just want to ask one thing. Like, one of the frustrating situations you have mentioned over here is that once you stop the steroids, again the inflammation comes up.
Yes.
It may be a P. acnes, or it may be an inflammatory reaction to the intraocular lens. So this is one of the most frustrating. What about Dr. Abhijit in the crowd? I want to know from Dr. Abhijit also. So what is your opinion on that?
There was a dictum that you should stop the taper off the steroid under the cover of NSAID. And NSAID can be given for a long time. It was a dictum. And if the patient is doing something like that, in my cases, I would like to cover with topical NSAID. And along with that, I want to highlight a little, I don't know how many of you have faced. In some of my cases, the patient come back with sudden red eye.
Yes.
After 7 days, 10 days, 15 days post-op. Otherwise, okay eye, So these were the cases of viral conjunctivitis. They develop on that operator.
Yes.
Exactly.
Because they keep on touching their eye with unhygienic way, So how do you actually diagnose these cases and not thinking otherwise?
So viral conjunctivitis, if it is, it's not a problem, because in our normally, I think in medical colleges, it is the steroids are not given.
We are happy if the patient comes with viral conjunctivitis, but in this case, so that is one.
But I think my steroid antibiotic combination, which is giving for the I'm giving for my post-operative post-operative regimen, that will take care of the viral conjunctivitis also.
No, in these cases, what they're going to do, like those patients, like you stop the steroid inflammation.
No. That's what I'm saying.
Okay.
In viral conjunctivitis, my personal treatment, I do use steroids also.
Okay.
So my treatment regimen will be, I will not, that will the regimen will do for viral conjunctivitis also. But this is a contested thing, that steroids are not used in viral conjunctivitis anywhere, but the locality I am working in, from my experience so my viral conjunctivitis patient respond to steroid very nicely.
In those cases, like not viral, in those cases we taper the prednisolone or dexamethasone, what you are using, you stop it. Can we use more weaker steroids for a longer period of time, like loteprednol twice daily? Because I have seen literature they use for 6 months also.
Loteprednol, what happens is that those patients which come back to us after stopping of the steroid dexamethasone combinations again come with a red eye, then I start on loteprednol or fluoromethalone mild steroids for another 20 days.
Yeah, there are actually two schools of thought. One is which you have said about loteprednol, and the other is which Dr. Abhijit has already cited regarding you tapering or stopping the steroids and continuing with the NSAIDs. I think this also works perfectly in the recalcitrant cases or where you have a recurrent case, no, after coming up after the surgery.
And addition of mild mediatic like homide at bedtime, 1 drop at bedtime, in the say refractory cases also helps for 4-5 days.
Yeah. Okay, thank you so much. I think we have already exceeded our time, and thank you so much for being present to encourage us in this IC. I hope it was beneficial for you. Thank you so much for attending.
Thank you.
Oh.